This is Bose Hamill from the Culinary Institute in Baylor in Houston, and in this video I'll be presenting a technique to reposition and refixate a dislocated intraocular lens with a capsular tension ring segment. This patient's undergone previous cataract surgery with an implant lens in the bag several years ago. Unfortunately, the lens has become dislocated and is causing him problems. The goal will be to utilize the same implant lens but move it into proper position and fixate it utilizing a capsular tension ring segment. Note, the patient does have some posterior capsular opacification, but YAG laser capsulotomy will be deferred until the repositioning and refixation is complete and the lens is stable. The capsular tension ring segment will be fixated 180 degrees from the area of maximal displacement of the implant lens, marked here. A conjunctival peritomy is made, and a fornix-based triangular partial thickness scleral flap is created as the anchor point. There are a number of different ways to anchor the CTS, and in this case I'm going to use 9-O-Prolene. Another approach might be to use Gore-Tex, at which point a flap may not be necessary, but a groove can be created in the sclera, but be sure to bury the Gore-Tex knot internal to the sclera to prevent erosion. In any event, I'll be using 9-O-Prolene in this case, and it will be a single-arm suture. After the paracenteses are made, the anterior chamber is filled with viscoelastic, a clear corneal incision is created to allow the insertion of a CTS. The next step is separating the capsule from the IOL. I use a viscoelastic and use hydraulic dissection to separate the bag. Note, you only need about a 3 clock-hour space to fit in the CTS. If the capsule is tightly applied to the IOL, separation can be initiated by utilizing a sharp needle on the end of the viscoelastic syringe to begin separation and start the hydraulic dissection and separation of the capsular leaflets. The CTS is then brought into the field, and care should be taken to orient it correctly. The eyelet should be at a more anterior plane than the curve of the ring segment itself. In this case, I'm using a single-strand 9-O-Prolene to fixate the capsular tension ring segment. So I pass the cut end of the Prolene through the eyelet, and I will tie this end of the Prolene to the eyelet with a 3-1-1 knot. To fixate it to the sclera, I'm going to use a CIF needle. I'll pass this in through the main corneal wound, and I'm going to exit slightly lateral to my previously prepared triangular flap. The reason for this is I'll pass the needle back through the sclera into the bed of the flap, and that gives me a little resistance to sliding of the suture so that I can better position the capsular tension ring segment and hold it in position as I tie the knot to permanently secure it. Here I'm sliding the capsular tension ring into the main wound, and I'll position it over the capsulotomy opening. A Sinskey hook is quite helpful here to position the ring into place and also to assist in placing the arms inside the capsular opening, as you can see here. Use of a second instrument and inserting the Sinskey hook from another paracentesis can help to elevate the capsular edge and facilitate inserting the ring into the capsular bag, and then utilizing both the eyelet and the joint between the capsular tension ring segment itself and the eyelet hook, the capsular tension ring segment can be fully seated within the capsular bag peripherally in the area that's been previously opened by hydraulic viscoelastic dissection. You should be careful to make sure that the eyelet is actually positioned above the anterior capsule. With tension on the anchoring suture, you can check to make sure the lens is moving in the correct direction and will be centered once the anchor suture is tied, as is seen here. As was discussed earlier, a pass is now made through the sclera to exit into the bed of the previously prepared flap, and this provides enough resistance to hold the capsular tension ring in place while the needle is passed again through the base of the flap and then tied to itself to secure the ring into position. Without this pass through the sclera into the bed of the flap, it can be challenging occasionally to both simultaneously tie the knot in the bed of the flap to secure the ring and to ensure that the tension is appropriate on the anchoring suture so that the IOL is held into correct position in the eye. As you can see here, traction on the anchoring suture through the superficial scleral pass is enough to hold the capsular tension segment in place and the lens in proper position while the anchoring suture is tied to itself. This can be further adjusted with tension on the anchoring suture during the knot throw itself. Once the anchoring suture has been tied and trimmed, the partial thickness scleral flap can be closed with a single 10-0 nylon suture through the apex.